Welcome, everybody. Again, this is Alex McDevitt with the RHSC Secretariat. We're going to go ahead and get started. Today, we will be hearing from Andrea Baer and Erica Beidelman from the William Davidson Institute at the University of Michigan. All of you should know Andrea fairly well, as she is the chair of the RHSC Market Development Approaches Working Group. And today, they will be presenting their Innovation Fund project, and the title is The Long Road to the Last Mile, a total market approach to family planning, learning from a private sector wholesaler landscape analysis for Malawi. So just before I turn it over to Andrea and Erica, a bit of housekeeping. All attendees are muted, and we will do a question and answer portion towards the end of the presentation. There's two ways that you'll be able to get your questions in. The first is there's a questions box where you'll be able to type in questions throughout the presentation, and we will address them at the end. Or during the Q&A section, you can use the raise your hand function that is in your webinar dashboard, and we will select participants who have raised their hand and we will unmute you. So with that, I'm going to turn it over to Andrea and Erica.
Thank you. And thank you all for attending. My name is Erica Beidelman, and I'm a research associate at the William Davidson Institute at the University of Michigan, and of course, joined here by my colleague, Andrea Baer. We're very excited to share the results of our Innovation Fund project with you today, as Alex stated, titled A Total Market Approach to Family Planning, Learning from a Private Sector Wholesaler Landscape Analysis for Malawi. All right. So our project goal was ultimately twofold, but we conducted numerous activities to reach these goals. So first off, our goal was to conduct this distributor landscape analysis, which had a focus on the wholesalers, but ultimately looked across all actors and sectors for family planning in Malawi. And the second part was to deliver a prioritized set of stakeholder receptivity tested solutions. So our focus country for this project was Malawi, but we also looked across success examples from other countries and sectors as well. We also tried to focus on rural and underserved populations here. So Malawi was chosen as a landscape with high donor involvement and limited private sector development to help answer the question of how the private sector can be prepared early on. So it was a small landscape, which helped us to gain a representative view of the country, with a relatively receptive government to the idea of inclusion of the private sector for family planning. And there also exists still a significant remaining unmet need for family planning there. Our overall research question for this project was, how can we foster the private sector provision of family planning products to rural and underserved areas to prepare countries like Malawi for the future? There were 5 major phases of the project, and at a high level, this includes our background research, our in-country interviews and data collection, a literature search for success examples from other countries and sectors, intervention idea development and a landscape assessment, and then the intervention testing and final recommendation development. So to answer our overarching research question and meet our project goals, we conducted many activities under 2 primary buckets. So first, our landscape assessment included our desk research, in-country interviews, analysis of some pricing and sales data, and a geo-mapping of outlets and need. So our in-country interviews were performed during September 2018, primarily in Lilongwe, Malawi, where we met with 31 stakeholders across numerous different categories, which you can see in our table on the right there. The geo-mapping we conducted was for the northern region of Malawi, with the use of publicly available data on facility locations across all sectors, and adding on the location types where legal sale of specific method types is approved. So our goal was to visualize where major pockets of need exist for specific method types. And although we won't go in depth on the results of this in our presentation today, you can always contact us if this is something that interests you. Our second bucket of activities was the concept testing and recommendation development. So we performed follow-up interviews with a subset of 10 of the stakeholders that are shown in the table here. These were chosen based off of engagement and knowledge during in-country interviews. The participants were asked to rate and rank 15 different intervention options. And then we additionally utilized other sector and country success examples to inform our final recommendations. So although we won't have time to go into detail on all of these activities today, we can always answer questions and reach out with information for those interested. So next we'll move into a brief introduction and overview of the family planning market in Malawi. So just to set some context on Malawi itself, Malawi remains a highly donor-dependent country with 100% of their government contraceptive supply sourced through international donations. Public sector facilities are free of charge to the entire population, and expectedly the private sector remains underdeveloped and underused. 84% of the population is rural, and 51% are below the age of 18, which presents significant delivery challenges for family planning in regards to these hard-to-reach populations. 80% of all family planning provision is through the public sector, but even 70% of the wealthiest quintile of women in Malawi still utilize the public sector as well. Malawi has a modern contraceptive prevalence rate of 45%, but women are still having, on average, one more child than wanted. And some previous research has hypothesized that this may be due to an overestimation of mCPR due to long-term inconsistent use of short-acting contraceptives. Meaning, for example, that though 45% of women are utilizing contraceptives, many of them may not be consistently protected due to either misinformation on how they are used or due to stockouts in government supplies. So the government has included the private sector in their plans for future engagement in policy and planning documents, but there's little formal inclusion of commercial actors to date. Now, we think a true picture of the entire family planning market is really necessary to develop our recommendations for the private sector. So to do this, we wanted to fully map the three major sectors, and here we are distinguishing the NGO and FBO sector, or the non-governmental organization and faith-based organization sector, which we're including social marketing under, from the commercial or private sector. So the public sector consists of numerous actors, including the Reproductive Health Unit, which governs policy and planning, the Central Medical Stores Trust, which procures, warehouses, and distributes products, and several distinct regulatory bodies which oversee pharmaceuticals and clinical practice. There's additionally all of the direct clinical facilities that exist from hospitals all the way down to the community health worker level. So product and service here is free for users, and all the contraceptives are dependent upon UNFPA, USAID, or different supplies. In the NGO and FBO sector, there's a few major organizations that exist in country that run different chains of clinics. So most of these, aside from the Christian Health Association, also operate their own outreach efforts in rural areas for family planning. The major actors include BLM, which is a Marie Stopes local affiliate, PSI, the Family Planning Association of Malawi, and the Christian Health Association of Malawi, which is an extensive faith-based chain of hospitals and clinics. So these NGO and FBO clinics provide mostly free product and services, though many static clinics often charge a modest service fee. The supplies stem from both donated supplies from the government and from international organization warehouses in the case of SMOs. These SMOs also have a limited set of socially marketed brands in country. In the private sector, there are no national chains or organizations. Most actors are individual private pharmacies, medicine stores, clinics, or wholesalers. And from interviews, it seems that at most a retail chain may consist of 3 or 4 locations. Products and services are paid 100% out of pocket, and there's no private insurance scheme that currently includes family planning. Both commercial and socially marketed brands are available here. So we also work to develop a mapping of contraceptive product flows for Malawi between the different sectors and across the market. This was developed based on information provided in interviews and is only applicable to the family planning products. So you'll see that while local wholesalers are not providing family planning products to the CMST or to FBO or SMO actors, they will sell other medical and pharmaceutical products to them. So we did note the differences here between donated and purchased product flows. You'll notice donated product stems from the CMST and runs through the public, SMO, and NGO and FBO clinics. NGO and FBO clinics outside of SMOs will only provide this donated product, while SMOs receive both donated product, their branded product, and products from organizational warehouses. The private actors receive product from both international manufacturers and local socially marketed brands from the SMOs like PSI and MSI. So during interviews with 10 wholesalers and 8 retailers and providers, we were able to observe contraceptive brand availability. You can see the list of brands by method type on the right, where the asterisk denotes socially marketed brands. For such a small private market, there is quite a variety in brand availability, particularly when it comes to emergency contraception and condoms. So 50% of the wholesalers we interviewed were selling at least one contraceptive brand, most commonly a socially marketed brand, while 100% of the retailers and providers were providing contraceptives. Most, even at the pharmacy level, were carrying orals, emergency contraception, injectables, and condoms. However, there were no contraceptive implants observed at any of the private sector outlets, whether that be the pharmacies or the wholesaler level. In contrast, the full method mix is available in most of the NGO and FBO clinics, and a full method mix minus emergency contraception is available in most of the public clinics and facilities. So during our interviews, we also worked to collect information on contraceptive prices. You'll notice that some prices are averages and others are singular data points, which is often due to product availability. So for commercial products, wholesalers often have an exclusivity agreement with the manufacturer, and at the retailer level, there was high variability in which products were being offered where. So retail prices across orals, injectables, and emergency contraception ranged from 87 cents up to $22.24. The Safe Plan socially marketed brand was the cheapest available on the market. And for orals, the commercial counterpart for the Safe Plan microgynon was twice as expensive. So for context, living wage in rural Malawi has been estimated to be $81.90, while GDP per capita has been estimated to be $28 per month. So average margins for the retailer ranged from 42% to 86%. But I would like to note that during our interviews, many stakeholders claimed that retailers were charging very high margins on products in the realm of 200% and upward. But from the pricing data that we were able to gather, we did not see evidence of this for family planning. Next, we will move into our interview findings surrounding challenges related to wholesaling and some of the opportunities we observed for further expansion. So according to the Pharmacy, Medicines, and Poisons Board of Malawi, which regulates pharmaceuticals and those who are selling pharmaceuticals, there are over 60 registered wholesalers. But from our interviews and research, it appears that there's about 10 or fewer that are primarily active and dominate the market. Overall, this is a high amount of wholesalers for the size of the private market, but it may have to do with the fact that many wholesalers also serve the Central Medical Stores Trust and the NGO and FBO actors as well when it comes to general medical and pharmaceutical products. So overall, from our research, we believe that existing wholesalers have the technical ability and capacity to reach family planning customers in both rural and urban markets. However, there's a major lack of demand, particularly in the rural markets, to incentivize their participation. So most large wholesalers gain their primary business from the Central Medical Stores Trust, partly due to the government's Buy Malawi campaign, which guarantees local purchase of a set of critical products as long as they're within a certain percentage of international prices. Wholesalers often report, though, difficulty in receiving timely payments from the CMST, which impacts their ability to invest in other markets. There is a largely growing customer base in the private sector for wholesalers. The number of private pharmacies and medicine stores have been ballooning in the past decade, particularly since Malawi began its pharmacy school and began to graduate newly licensed pharmacists. So primary challenge for the delivery of private sector family planning is the limited overall business for commercial contraceptive brands. However, emergency contraception is a noted exception, which we'll discuss a bit later. So demand generation remains a challenge. As we noted earlier, 70% of the country's wealthiest women are not purchasing their family planning. Key quotes also emerged from several of our interviews in regard to the predominant themes and challenges for the wholesaler experience, which you can see on the left. Summarized, these yielded 4 major conclusions. Subsidized products discourage wholesaler participation in many ways. Margins are often too low for subsidized products at the volumes available. And because the largest wholesalers in country are selling these products, smaller ones cannot gain volume necessary to encourage their participation. The subsidized product sets also limit their ability to bring in commercial brands due to the heavy price competition. Stakeholders also reported a challenge with the absence of price or margin regulation in Malawi, which many stakeholders claim is leading to high end user prices or discouraging the use of the private sector overall. There are also many issues surrounding information across various levels of the family planning market, which we'll go into depth on shortly. And pharmacists are not licensed to administer the most popular contraceptive method type injectables, which may further limit use of the private sector for family planning among women. We work to further define and disaggregate the key challenges as follows. So the 4 primary buckets we use to categorize challenges include provider and channel limitations, insufficient private sector demand, market misinformation, and labor force challenges. So additional challenges did come up during our interviews, but these were what we felt were the most prominent ones. So I'm going to go through and highlight some of these key challenges and observations. So for the first bucket, provider and channel limitations. So some women do purchase injectables in the private sector, as was seen from some preliminary sales data we were able to gather. But the inability of pharmacists to administer is a major deterrent for women who would otherwise utilize this sector for family planning. If pharmacists could inject, retail locations would present an opportunity for women who are not near a clinic to access their family planning. We also observed that while the public sector was experiencing a major DMPA stockout, the private sector locations still had stock available. As well in Malawi, HSAs, who are a cadre of community health workers, are able to administer injectables to women, and they have far less clinical training than pharmacists. So pharmacists may be a good potential option to expand access as well. Then moving over, so not only are subsidized products dominated to the private sector for family planning, but free public sector products dominate the market as a whole. There's currently no price discrimination mechanisms in Malawi, so even those with the willingness and ability to pay are still continuing to access through the public sector. Then moving down to market scale, a lack of market scale presents a significant barrier where total volumes of contraceptives are often too small for wholesalers to meet manufacturer volume requirements, or if they do order, they face significant expiry risks when ordering in large quantities. So stakeholders also reported that the perceived small market size of Malawi has discouraged manufacturers from registering new commercial contraceptive brands in country in relation to what the price of product registration for the country is. High operating costs for both wholesalers and pharmacies may additionally influence pricing for contraceptives in Malawi, as well as pharmaceuticals as a whole. So both are required to keep full-time pharmacists on staff, but securing high-quality pharmacists requires a lot of resources beyond salary. The next category, market misinformation, I'll skip over for a second, and I'm going to go in detail on this on the next slide. So labor force challenges then are also persistent, a major challenge being the lack of pharmacists and potential healthcare business owners who are willing to go into rural areas. Demand may be present in these areas, but private sector outlets are few, particularly the pharmacies. So pharmacies present a greater challenge than medicine stores, potentially, because they require a full pharmacist on staff to dispense drugs, whereas the medicine stores only need potentially a part-time pharmacist there. So overall, many of the challenges and lack of development in the private sector may be related to issues surrounding information availability, leading to both a low demand and low available supply. So on the demand side, there are a lot of cultural barriers and misconceptions surrounding family planning products. There's a high need for accurate information among the population, and this need is exacerbated for youth. So as we mentioned, 51% of the population is under 18. However, contraceptive information is not permitted within or near schools. Alternative ways to reach youth and thus generate demand are necessary. Most information campaigns focus on what is available in the public sector, but little information is known within the population about their private sector options. Therefore, if a brand is not recognized in the private sector, perhaps because it differs from the product being brought in through the donor fund, women may be less likely to utilize it. Public sector outlets are often overburdened by large volumes of clients. Therefore, the retail outlets provide a quick fix for those who know what they need. On the supply side, there is little information for wholesalers, retailers, and the manufacturers on what the actual market potential is for family planning in Malawi. From preliminary sales data, we saw evidence of demand and willingness to pay in retail outlets that were well stocked with contraceptive options. This was present in both a semi-rural and an urban area. Greater efforts to characterize demand and willingness to pay can work to incentivize market actors' participation. Many outlet types could serve as information sources, particularly those frequented by women often for other needs such as over-the-counter medicines like cough syrup. In addition to the challenges, we also observed 3 key opportunities for private sector expansion. Emergency contraception is a key opportunity in many ways, particularly as an entry point for private sector access for family planning. It also presents evidence of demand for contraceptives in the private sector that can be used to encourage further participation. Preliminary sales data also shows that there is a significant monthly demand in both semi-rural and urban locations for a host of contraceptive products. This provides evidence that there exist user segments with an ability and willingness to pay. And if this can be better characterized and defined, it may also be used to encourage market participation. Finally, the pharmacist community has been seen as largely entrepreneurial, with many opening new pharmacy and medicine store businesses in addition to their full-time jobs. However, the bulk of these activities are occurring in city centers, and interviewees described that entrepreneurs face difficulty in obtaining commercial loans to start new businesses and often use private funding. When it comes to newly graduated pharmacy students, private loans are incredibly difficult to obtain for starting a new business. Though these may be the people most likely to move to rural areas for new opportunities due to their younger ages and lower likelihood to already have an established family. There is a large opportunity for catalytic investment through the financing of young pharmacist entrepreneurs for rural retail locations, which could in turn help to stimulate a social enterprise environment. So I want to dive a little bit deeper into the topic of emergency contraception in Malawi. So this product presented as an exception to our general observations about the private sector family planning market and provides an example of how private sector wholesalers have the ability and the willingness to step in and fill a market gap for contraceptives. So emergency contraception is often not available in public facilities as it's often not a nationally ordered product. Women also encounter a lot of stigma and long wait times for this product when it is extremely time sensitive for them. With greater information availability, emergency contraception may be a potential way to convert women to longer-acting methods that may be more cost-effective. Many actors reported concerns about over and improper usage of emergency contraception, largely due to the lack of information surrounding it. One wholesaler in particular noted that they do not carry the product due to their ethical concerns. There is further opportunity for this contraceptive option to be made available to women in rural areas due to the lack of retail outlets there, which is a good transition to our final point here from our interviews. So retail pharmacies are women's primary source of emergency contraception, but pharmacy proliferation is currently limited to major urban areas and their immediate surroundings. The sector has not yet fully branched into rural areas, so there may be a large segment of unmet demand for EC in these areas, particularly within the concept that it's not being stocked within public facilities. So the screenshots on the left here are from our geo-mapping work. This is a geographic segment from the northern region of Malawi. The green background here represents population density, and each point represents a facility. The circle around the facility is a different color depending on the sector. And then you can't really see here from the scale of it, but there's also a little icon within the facility marker that shows what type of facility it is, whether it's a pharmacy or a clinic or a hospital. And then the circle surrounding them will denote the catchment area for that facility. So we just use the standard 5-kilometer catchment area for all. So the top image here shows the facilities in that area that are permitted to sell or most often stock emergency contraception, while the bottom image shows those facilities that are permitted to sell or most commonly stock orals and injectables. The difference between the two is quite stark, showing a real gap in access to emergency contraception, despite numerous stakeholder reports that this is a preferred and high demand product among women in Malawi. Pharmacies are a key access point for women who want discreet and self-managed family planning, yet only 9 of Malawi's 60 retail pharmacies are in the northern region. And within the northern region, over 30% of all facilities sit in the capital of Mzuzu, yet only 10% of the northern region's population lies there. So I'll now turn it over to Andrea to go into our intervention development and stakeholder testing.
All right, great. Thanks so much, Erica. And hi, everyone. This is Andrea Baer. And like Erica, I'm happy to be talking with you today to share the results of our work. And thank you, everyone, for joining. So moving from the market assessment and interview findings, we'll now discuss the ideation process and testing, and then the results, and then take a look at case studies from other countries. So a priority of our project from the outset was to consult with Malawi business people and in-country family planning implementers and other observers of the environment, both for idea generation and scoring. And as Erica presented, we identified a set of challenges and opportunities faced by the for-profit sector, as well as the family planning environment during our in-country research. During the work, we generated ideas for market building based upon trying to address root causes of the various challenges and gaps that Erica outlined. The ideation and scoring process with stakeholders was quite instructive. They shared pros and cons, they proposed key conditions, and they challenged and raised questions. In seeking their reactions, we also asked for scoring on a 1 to 5 Likert scale for both feasibility of implementation as well as level of potential impact. And by impact, we asked them to think of that as the extent to which the intervention could increase private sector access to family planning in rural underserved areas. Through this process, we developed and tested 15 market building interventions with stakeholders. And then after they reviewed all 15 interventions, we did invite each stakeholder to select their top 3. In other words, which ideas they'd most like to see advanced in order to develop Malawi's private sector for family planning at the last mile. So moving ahead to the results, I'm not going to show you the results about all 15 interventions, but instead we're going to zoom in on about 7. And as you can see from my headline here, basically we'll report that there were 4 ideas which really dominated in terms of the stakeholder voting process, and then a couple of additional interventions that also stood out. So orienting you to the table, the first column shows a summary of the market building intervention, really just a title for it. And then we have a column for to indicate that those ideas ranked in the top 5 for feasibility and impact, respectively. And then I flagged 3 of the ideas with asterisks to indicate that those also received multiple votes when stakeholders selected their top 3. And note, it's just coincidental that I have 3 flagged as top 3, and I'll explain more. So to talk a little bit more about the ideas here, and I think we'll begin to see how they relate to the various market issues. First, the 2 ideas that made it to the top in all 3 categories are the ones with the 2 asterisks towards the top. First, a nationally representative willingness to pay survey, and secondly, the idea of self-injectable cyanopress for sale in pharmacies and to specifically target rural women seeking self-care. We'll talk more about those as we move forward. Next, I'd like to draw your attention to the top 2 ideas, the private sector-based contraceptive information campaign and the emergency contraception information campaign. Again, these both ranked and rated very highly among the stakeholder group in terms of both their feasibility as well as impact. The first idea proposed to focus on information dissemination in the private sector, more broadly to explain what products and services are available in the private sector. And then the second idea was more of an EC-focused initiative regarding appropriate use, helping users understand the actual cost to them, and to prompt user transition in some cases as appropriate. Finally, there are 3 additional ideas that I want to highlight from this page. The 5th line reads as add private sector representation to cross-sector FP working groups. This is pretty self-explanatory, and we'll talk more about that one as we move forward, but basically it relates to engaging that sector along with what has been predominantly a public and social marketing oriented technical working group within Malawi. The next item says create a program that parallels ART service provision, and this refers to antiretrovirals, and it relates to the idea basically of using the private sector as a mechanism to increase access to program drugs. So it has benefit, certainly, and it could increase access, but it's less about private sector development per se. And then finally, an idea that was in the top 3 picked very often, and people I think tended to see this as a pretty bold, innovative idea, was some type of piloted business model for a mobile or rural pharmacy concept. So we'll talk about these more as we move forward, but at this point, let's move on to examples from other countries and think about evidence, because we want to try to build on evidence from what works. So we found 6 predominant types of market building examples, and you'll note that none of them are focused on the wholesalers per se. Running through these very quickly, the first is the idea of a fully integrated government strategy. Many of us know this example from Indonesia, where they started in about 1997 and had a very long, highly integrated effort. The second is what I would call provider entrepreneurship models, and these take the form of the Mary Stopes ladies, DKTBs, and Living Goods not being necessarily FP focused, but again, basically the idea of community-based distribution, taking the product to the women, but with a private sector structure. The third is what I like to think of as funded demand, and that is getting to the point where family planning benefits are included in health insurance systems. And in this case, this is both a policy and business advocacy initiative. In Tanzania, Johns Hopkins undertook a significant evidence and advocacy effort to persuade AAR, the largest insurance provider in that country, to include family planning in their covered benefits. And it's pretty easy to see how this could address a root cause of wealthy and employed women that are still going to the public sector. Fourth is the idea of rural pharmacy investment, and this example comes neither from Asia nor from sub-Saharan Africa, but it's rather what's been done in countries such as the UK, Greece, and Scandinavia, where they recognized that they needed to have business measures to ensure that there were, in fact, rural pharmacies to serve areas with low density populations. So that strategy is obviously not limited just to pharmaceuticals, but would have broader benefit. Moving down the list, the next is a familiar one for many, and that's the idea of what SMOs can do in market building. So DKT in Brazil and PSI in both Myanmar and Vietnam were both examples relative to condoms and how they took a market segmentation, product portfolio, and very strategic pricing approach to facilitate development of the commercial sector. And then finally, and somewhat related to the provider entrepreneurship, is the idea of new provider models. And this example comes from Tanzania with Duka Dawa, and basically what was a policy and partnership to create accredited drug dispensing outlets. That effort notably also involved changing consumer expectations and behavior. And then in that case, of course, the wholesalers opened district subsidiaries to serve the ADDOs. So I probably don't need to spend too long on this slide because I think it becomes relatively obvious what the common success factors are, but just running through them quickly, and as we would think about how to apply these to a country like Malawi or a similarly donor-oriented country. Number one, strong government interest and commitment, right? Secondly, formal mechanisms to include private sector actors in critical market processes. Third, approaching the development of commercial markets from both a demand and a supply standpoint. And note here that when we talk about demand, we're thinking about need plus the ability and willingness to pay in some fashion. Fourth, obviously thinking about channel models that recognize where and how women wish to obtain their materials. And then related to that, the role of social marketing organizations and how they can play a direct positive role in fostering the commercial sector. And finally, the point that efforts really often take a long time. We're talking about medium to long-term time horizons. And these often require in-depth market studies, evidence development, and stakeholder engagement. And the case studies noted that it's critical to consider private sector strategies early on, even when a country still has a high level of donor involvement. So the point is, there's no shortcut, and there's not necessarily a lot of low-hanging fruit, and it's never too early to start. So we've shown you a lot of information. I think we've covered a lot of ground. Returning to our original project goal, we were setting out to generate stakeholder-tested, actionable recommendations for developing the private sector for family planning in a country such as Malawi with a pretty nascent environment, particularly in the rural, remote areas. You heard from Erica about our market assessment, the interview findings, and got a glimpse into the geo-mapping. We ran through pretty quickly the stakeholder intervention scores and have touched just now on other country and sector examples. And from this work, we were ultimately looking to arrive at a development of market building recommendations for Malawi. All right, so that brings us to our recommendations for Malawi, and we have 5 recommendations in total that we split into 2 groups. And again, broadly, what we're looking to do is to think about how to unlock and start to develop the private sector for family planning in the rural environment. So our first 2 recommendations are specifically for what we would call existing initiatives in Malawi. The first recommendation is to include private sector representatives in Malawi's family planning technical working groups. This gets at a market issue really around partnership and common goals and full understanding and full lens into what the environment is. We see this as pretty low, of all the activities, this is probably pretty low hanging and also a fundamental building block. Malawi's current implementation plan for FP calls for a better understanding of the private sector's role and does commit to creating more opportunities for public-private partnerships to strengthen FP service delivery. So formal inclusion of these actors in the working group mechanism is a pretty obvious way to increase this mutual understanding and create a forum for moving forward. The one thing I really want to note about this recommendation is that we're specifically saying it must extend beyond the social marketing organization representatives who are already on board. we recognize that they often straddle the line of public and private sector, and certainly they can often reasonably argue that they participate in the commercial sector, but the fundamental fact of having some donor funding and not having to be purely for profit changes the nature of that outlook. Finally, on this first recommendation, this would not require any funding and would primarily involve identification of representatives, defining roles and responsibilities, and then reaching out to people. We would suggest considering potentially 2 wholesaler individuals and 2 retailers who could represent views from their sector and also share high-level information back. Moving on to the second recommendation on this page. Again, it relates to an existing activity, actually. And that is that we propose that projects such as the ongoing Cyanopress launch in Malawi would be targeted to rural and underserved areas with greater access barriers, rather than what tends to be a more common earlier focus on urban and peri-urban areas. And so this work, for those of you who may be less familiar with what's going on in Malawi, is following from an FHI 360 Mangochi district study that really showed how well rural women could do with Cyanopress in terms of continuation rates. And so the Ministry of Health and PSI is working on this project initially already. And certainly we would note that this concept would need to fully reflect the current in-country situation and the Ministry of Health's plan with respect to the pilot introduction of Cyanopress. But broadly speaking, taking more of an integrated approach to prioritize rural areas sooner for a new product activity could really extend the launch and scale, target underserved women, and importantly, provide opportunities for development of the rural private sector. So it's more like taking a product and market focus at the same time. All right, so moving on to the 3 recommendations that we developed and put forth that would involve new investment in order to develop the private sector in rural Malawi. Our third recommendation, and the first in this set, is to establish a joint public and private sector communication strategy in order to build FP awareness and demand in rural, remote, and underserved areas. So obviously this is going to address the market issue of consumer knowledge and could particularly address the needs of youth, as Erica has highlighted earlier. The key goal would be delivery of coordinated information across all sectors so that women can be aware of all facility types and contraceptive product options. And this could be developed by a cross-sector task force that could play out of the family planning technical working group that I referenced earlier. Final point on this recommendation is that we would propose to include a sub-campaign specifically focused on emergency contraception, aimed at providing women with accurate information surrounding its use. And for both of these recommendations, again, as you saw the table earlier, and I'll just re-flag it now, these were both rated pretty highly by the stakeholders that we consulted with. These activities of the joint communication strategy and the EC information campaign would require funding. Then moving on to recommendation number 4. Here, this really relates to the issue of market data and helping market actors and potential market actors understand the potential in a market. Here, we would propose a market study within a nationally representative sample to go after 2 issues. First, the willingness to pay concept across consumers, and secondly, a retail pricing audit. This obviously would require funding. It could, this type of 2-pronged study could be implemented by an objective third party through partnering with Malawi's PMPB, possibly the Medical Council of Malawi, and certainly the Reproductive Health Unit in the Ministry of Health. the results would provide this critical information on market potential and segmentation, and also really start to inform future processes around shifting consumer expectations and behavior around willingness to pay, which we know is an important component in countries' evolution as donor landscapes change over time. All right, moving on to our final recommendation. This is specifically channel focused, and it would address what I think of as sort of a channel desert versus saturation issue specifically for retail pharmacies. We propose that there be an undertaking to invest in a retail pharmacy channel for rural areas, whether it takes the form of a mobile pharmacy or some type of alternative service delivery model. This would address the current misalignment of new pharmacy business locations with the population needs and work to address the difficulty of incentivizing business placement in highly rural areas. Well, certainly there are challenges to catalyzing such development, but at the same time, we saw a strong environment with many talented and entrepreneurial pharmacists, both within wholesaler and retailer organizations, that could be tapped as change agents to help design and deliver services to rural regions. In other countries, just a comment here, in other countries where there's a much higher rate of mobile phone and internet subscription and access, digital platforms for increasing access and knowledge may be more appropriate, but in this case, in Malawi, at the stage of development they're in, we believe that some type of in-person mobile concept is really required. And we saw, again, considerable opportunity and enthusiasm for diving into the design questions around this particular recommendation. Ultimately, there's an appetite within Malawi for looking at how to channel the entrepreneurial energy of the growing pharmacist community. And with that, I'll go to our final slide so that we can have a few minutes for questions. Let's just conclude by reflecting as well as looking forward for Malawi and similarly situated countries. First, we all know that this work is timely given the ever-increasing emphasis that's being played on the role of the private sector, and we thank RHSC for funding this work. We were excited by the interest that we saw for market building in the private sector, and while our recommendations are ultimately focused on Malawi, the basic concepts apply to other highly donor-dependent countries as well. In terms of next steps, we're going to complete dissemination of our work and our final recommendations with a particular focus on our in-country partners there, and see what we can do to advance some of these recommendations with relevant donor organizations as well as in-country partners. And to that end, we're particularly interested in developing concept notes specifically around recommendations 3, 4, and 5. And that concludes our presentation. Again, we thank RHSC for funding this research and ideation process. And we want to say a special thanks to many colleagues in Malawi for their engagement and contributions. And now we can open it up for questions. All right. So first question we see is, can we share the presentation? And the answer is yes. We will be making it available on the RHSC website. All right. Let's see. We're just looking through the questions. There's a question that says there are several references to lack of pharmacist motivation for servicing rural areas, but is there sufficient opportunity in rural areas to support profitable private sector pharmacies? So that's a great question, and the answer is somewhat still TBD, but notably this is why we were proposing a mobile concept. that would specifically not necessarily be static, but it could be co-located with medicine shops and basically have a rotating schedule for where it would go.
Yeah, and I think this is also why we're proposing the willingness to pay audit as well. From some, a very small set of sales data we were able to gather, we do think that there's the potential for some unrecognized demand in these more rural areas, but definitely a very FP-focused willingness to pay study would really help to characterize that.
All right, let's see, when we're taking a look at the other questions here. Someone asked if we could talk a bit about the Family Planning Association in Malawi. Yep, we're happy to do that. We did speak with a representative from the Family Planning Association. They tend to focus in particular geographies, and they run a handful, and literally I think it's a handful of youth-focused centers.
I think they're also an organization that is trying to move towards a more sustainable model. I think they were in the process of just beginning to charge some modest service fees in their different clinics when we were in Malawi.
Let's see. All right, so the next question is, how many people can really afford to pay in the rural areas? So thanks for this question. And Erica just touched on it briefly when we were talking about the willingness to pay survey. One of the things we found, honestly, in our work is because we went in with kind of this focus on the wholesalers and thinking that there was something that we needed to do, maybe that was a hypothesis, that there was something that wholesalers needed to be motivated around in order to get them to serve the last mile. And what we actually found is that while they're not routinely delivering out very far at this point, it's really based upon lack of outlets to the market. And there, anecdotally, we heard that there's potentially a larger interest and willingness to pay than might be observed. And as an example, one trading center area that we did have the opportunity to visit, and Erica mentioned that we were able to review sales data. We did in fact find that there was a considerable volume of out-of-pocket purchases for all the products that were available in the pharmacy, including, notably, injectables, even if the person then had to take that injectable elsewhere for administration.
Yeah. And this was a pharmacy in an area where, for the past year or so, it had historically been the only pharmacy there.
Yeah. Erica, do you want to take the next question? So it looks like we have, we speak about pharmacists, but often the personnel in drug shops are not medically trained at all. How would you handle that in terms of distribution and use of cyanopress? So this is Andrea. I'll just comment on that. We were not intending to imply by any means that the medicine shops would be the dispensers, if you will, of cyanopress.
Yeah, I think we were really meaning it for the pharmacists themselves. And Malawi does have a history with training, non-medical professionals how to appropriately inject DMPA, these health surveillance agents within the country who have a very, rigid training programs to make sure that they can do this appropriately. So I think it's not necessarily too far of a stretch to then think that pharmacists could undergo a similar training, especially with their pharmaceutical knowledge.
Absolutely. And in fact, as Erica mentioned, the fact that community health workers are currently trained and allowed by the government to administer Cyanopress. And in the case of this Cyanopress expansion, it's actually focused around teaching women to self-administer. So you could picture that you'd have periodic visits in the rural designated locations in order to provide the initial training and service, and then do follow-up, as opposed to the actual administration. And then, yeah, and we just want to thank a participant who shared the fact that in Malawi, the CHWs and HSA provision of DMPA SC and SI is being prioritized as a mechanism for reaching more rural women. And this person shared, I'm sorry, we didn't catch the name, but this person shared that the initial districts were selected based upon mCPR rates, which makes a lot of sense. Let's see, and then there was a question about our ideation process. So basically, we did the initial ideation in mostly one-on-one interviews with the 30 people that we met with during the time period in September. So we were asking them about their perceptions of the challenges and opportunities in the market. And then at the same time, later in the conversations, we asked them about their ideas for how to motivate development of the private sector.
Yeah, I think we then also combine that with some of the information we've seen from, you know, the other country examples and other common challenges that people reported, to then have, you know, a mixture of some ideas developed purely from in-country stakeholders, and then additional ones that we added.
And I'll just say, because I know we're running out of time, and so Alex may want us to wrap up, that we welcome anyone to reach out to us. Our information is on the screen there, and we really appreciate everyone's participation, and by all means are excited to continue the discussion. And so we'll take this last question maybe before we conclude, and it was, did you explore the rural mobile concept with any of the private traders, wholesalers, to get their perspective on business case feasibility? The answer to that is yes, we did. And although in this project, we were not able to actually develop the numbers around the business case, we did receive positive input, and in fact, at least a couple of entities that might have some level of interest in essentially forward integrating to help develop that type of model.
Yeah. And I think stakeholders also really stressed two key points that would help make this successful. And they were very clear that they think the pharmacist in charge or whoever was in charge really needed to have an ownership stake in this model to ensure that the goods and the vehicle or whatever is being used within it is really taken care of and really prioritized. And then also that it really needed to be a blended pharmacist plus perhaps a clinical person together as a team to really extend access to not only family planning, but other services and products that would encourage women and their families to visit these more mobile pharmacy locations.
Yeah, thanks, Erica. Great points. All right, so we will wrap up. I'm sorry if we didn't get to all the questions. Please absolutely email Erica and I. We're really delighted for the interest. And the recording will be posted in the listserv and on the RHSC website. And again, we're happy to share the presentation. So thanks, everyone, and have a great day or evening. And we hope to talk with you soon.
Thank you, everyone.
Thank you, everybody, and thanks, Andrea and Erica.
All right, thanks. Bye.